Assalamu alaikum. My name is Uzair Ali, and I am currently working over here at PARSA ECHO Pakistan as the project coordinator. Before we start this session formally, we have to go through some standard announcements. We are a part of global movement called Project ECHO, based in USA, with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation so that you can unmute yourself for questions or use raise hand option or use chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel. The link is will be shared in the chat box. For CME credit, please contact me. I will share the link in the chat box, which will be active for 12 hours only. So you are requested to fill it out as soon as possible to avail the opportunity of CME. For the convenience of the participants, the session is bilingual. Please speak in Urdu or English, Hindi, whatever language you are comfortable in. If you are interested in PARSA ECHO Pakistan publication, please fill the form that would be shared in the chat box. Now I would like to hand over the mic to Dr. Jitin Kumar to introduce the speaker formally. Dr. Jitin, the mic is over to you.
Hello everyone, am I hearable?
Yes.
This is Dr. Jatin Kumar, a second year MBBS student from LUMS, Jamshoro. Today I will be introducing about SAYA, non-profit organization. So uh, let me share my screen. Is the screen visible?
Yes, it
So,
is visible.
actually, SAYA is the first patient clinical led non-profit organization in the IBD space. With a dramatical increasing on numbers of IBD in the South Asia, SAYA has formed to create resources, research, and education for IBD patients and healthcare providers of South Asian origin to minimize disparities, dispel stigma, promote early diagnosis, and improve access of treatment. Saya has many structures like the board of directors. The Saya main structure is like for research and professional development. Saya, there are many directors of Saya board directors which are given in this presentation. In the form of professional development, this is CI programming to educate general practitioner and gastroenterologists about IBD, its pathogenesis, epidemiology, and how to provide the best care and treatment of patient and setting in the South Asia. When we come about the research in the SAYA, there are many players like said gastroenterology and clinical gastroenterology, in which we are identifying actually the challenges and the opportunities to the healthcare in South Asia, and well received as an important of first paper acknowledging the troubling economics of IBD in IBD care in South Asia. When we come about research initiatives, there are many research publications which are given the website of SAYA, where you can check about the research done in the SAYA. SAYA is also about not only the it is actually a non-profit organization, but it also encourage the patients to educate and initiate its. There are many support groups about SAYA, and when we go to their website, there are many groups like SAYA student check about the website. Let me introduce
Dr. Kumar, I think your microphone's not working properly because we can't hear you. But if everyone can hear me, then I can maybe just introduce myself, I guess. So I'm Dr. Waqqas Afif. I'm a gastroenterologist at the McGill University Health Center in Montreal. And my parents are from Pakistan, but I was born here in Montreal, so my Urdu is a little bit anglicized, but Urdu में question है तो Urdu में और सी बात कर सकते हैं. Okay, so I'm going to just share my slides. And, okay. Okay, so I hope everyone can see my slides.
Yes, we can.
Yes.
Okay,
Yes,
perfect. Okay, so I was asked to talk a little bit about drug therapy for inflammatory bowel disease in 2023. These are my faculty disclosures. So we'll talk about the treatment goals in patients with inflammatory bowel disease and then briefly review the medications used in the treatment of IBD. If you have any questions, you can always just interrupt me or on the chat box as well. Okay, so just in terms of inflammatory bowel disease, so you know, there's two types of inflammatory bowel disease, either ulcerative colitis or Crohn's disease. I'm not going to go into the whole etiology and you know, epidemiology of inflammatory bowel disease. So certainly we know that it's quite common in North America and Western Europe, and in South Asia and Southeast Asia. There's been rising incidence and prevalence as well. So just in terms of questions that we ask clinically, or things that kind of hint that there's something else going on besides you know, IBS or irritable bowel syndrome, and we worry about more inflammatory conditions. So in patients that have a non-healing or complex perianal fistula, in those patients that have a first-degree relative that has IBD, if you've lost significant weight in the last 3 months, chronic abdominal pain for more than 3 months, nocturnal symptoms, mild fever, and then if you have rectal urgency, those are all sort of indications that there might be something going on that you might need to investigate a little bit further with different investigations. So what are the investigations that we usually order in patients that come in with GI symptoms like diarrhea and blood in the stools and abdominal pain? So we usually start off with just basic labs, the CBC, CRP, liver enzymes, and IgA and TTG to look for celiac disease. For stool studies, still CNS, ONP, and C. difficile, so looking for parasites and bacteria and C. difficile. We know that patients with IBD have a higher risk of C. difficile as well, so that's why we use that on a regular basis. And then fecal calprotectin, which is a relatively new test. So it's a fecal test looking for neutrophils, fecal neutrophils, and so that gives us an idea of whether there's any active inflammation in the bowel. So it's a little bit more sensitive and specific than CRP for looking for inflammation. That helps us a lot in patients that have symptoms, and they can sort of help differentiate between an IBS patient, an irritable bowel syndrome patient, and an inflammatory bowel disease patient. And then obviously there's endoscopic evaluation, so either with a gastroscopy or a colonoscopy. We can do a small bowel enteroscopy or capsule endoscopy. And then radiology, ultrasound, cross-sectional imaging of the abdomen with a CT or an MRI will help delineate the small bowel a little bit. So just in terms of fecal calprotectin, I don't know if that's really available in Pakistan or not. Maybe if can anyone tell me if it's actually available there, you know, easily accessible?
Yeah, Waqqas, it is freely available in Pakistan, and we use it widely in diagnosis as well as later on in monitoring.
Okay, awesome, great. So again, it has a very high sensitivity and specificity, so it helps a lot in terms of differentiating the IBS patient versus the IBD patient. And also, as was mentioned, in patients that have inflammatory bowel disease, we can certainly use that as a way to follow patients to make sure that they get into remission. So in terms of treatment targets for inflammatory bowel disease, so things have changed over the last little while. And so these are the new sort of guidelines that were published last year. looking at what we should be targeting. So in the short-term target should be symptomatic response and symptomatic remission. So that's a decrease in the amount of rectal bleeding or abdominal pain and stool frequency. And then also in the intermediate target, you want an improvement in your CRP and fecal calprotectin. So that's biochemical remission. And then the long-term target that you sort of assess anywhere between 6 and 12 months after you've started a new therapy is endoscopic healing or endoscopic remission. And if you're able to get to that endpoint, then you can use, that helps patients' quality of life and helps with patient disability as well. Sometimes in patients with ulcerative colitis, we can look at histologic healing. There's a lot of new studies taking a look at whether histologic healing is a better endpoint than endoscopic remission, because there have been some studies that have shown that if you can get to histologic healing, in other words, your pathology is normal, that there's a better chance that you'll stay in remission over the long term. So the reason why we pick endoscopic remission as a long-term outcome in inflammatory bowel disease is that we know that if you can get to that endpoint, whether you have ulcerative colitis or Crohn's disease, it helps to avoid surgery. So if you're able to get to endoscopic remission, the chances of needing surgery are much less over the course of the next few years. So this is why one of the reasons why we target endoscopic remission for our long-term outcome. And so in terms of how we manage patients, so this is where fecal calprotectin is very helpful. So when you start a new treatment, you assess them clinically, but you also assess them biochemically, and you monitor them regularly over the course of the next 6 to 9 months with blood tests, clinical assessment, and fecal calprotectin, and then optimize therapy as needed. And then hopefully you're able to achieve your target of endoscopic remission, within the course of a year of treatment. The reason why we sort of use this treat to target approach, where we sort of are assessing the patients a little bit more frequently, is because of this study. This is the CALM study that was published a few years ago. And so in this study, they took patients that were on adalimumab, so an anti-TNF medication that we use for ulcerative colitis and Crohn's disease. And these are Crohn's disease patients in the study. And they compared dose escalating those patients either because of clinical symptoms or ongoing prednisone use, or escalating also based on fecal calprotectin and CRP. So in the optimized arm, if you had elevated CRP or fecal calprotectin, but you felt well and you didn't have any symptoms, you would still be optimized. So you're basically optimizing to improve your biochemical markers as opposed to just clinical symptoms. And what they found was that if you have a more intensive monitoring and dose escalation for this tight control group, the chances of having endoscopic remission or mucosal healing was about 15% higher, so 45% versus 30%. So in clinical practice, this is what we do. So we assess the the CRP and the fecal calprotectin and patients' clinical symptoms every 3 months or so. And if they're not where they should be in terms of being in remission, then these are the patients that we either dose escalate or add therapy or change to a different therapy. So I'll spend a few minutes now talking about IBD treatment. So, it's hard to talk about IBD treatment in 20 minutes for all of inflammatory bowel disease, but just to sort of get an idea of what we use in terms of medications and what new medications are available. So most of the time we decide to choose one medication over another based on the severity of symptoms and the severity of inflammation. And so there are certain risk factors that you worry about that would probably, require earlier use of biologic type medications. Whereas if patients don't have these risk factors, then you can start using, you can use other therapies, especially in patients with ulcerative colitis, where we have a good therapy available with 5-ASA medications. So just to go over the treatments that are available for patients with IBD. So 5-ASAs, you're quite familiar with, most likely, and this is for ulcerative colitis patients only. And you can use 5-ASAs to induce patients into remission, but also to maintain patients in remission. That's orally or rectal treatment. Corticosteroids, so you can use corticosteroids. So for UC, for patients that are failing 5-ASA, you can use corticosteroids to induce remission. And for Crohn's disease patients, you can use it to induce remission. But you can't use it to maintain remission. So if you're on steroids, it's usually a bridge to a different therapy, either to start 5-ASA for the first time or an immunosuppressant or biologic medications. So it's very good to induce people into remission, and it works in about 70 to 80% of patients, but you can't use it to maintain because there's side effects associated with it, and also it doesn't work very well. So there's immunomodulators like methotrexate, which is available for induction and maintenance for Crohn's disease, and thiopurines like azathioprine or 6-MP that you can use for maintenance treatment. So someone that's in remission that you want to keep them in remission, there is data to suggest that thiopurines are somewhat useful, but we'll talk about that in a little bit more in detail. More and more, we're using biologic medications and small molecules, and anti-TNFs are widely available, so either infliximab or adalimumab, and that's you can use for ulcerative colitis or Crohn's disease. Vedolizumab, which is a biologic medication that targets the alpha-4 beta-7 receptor, which prevents white blood cells from entering into the gut. Is approved for ulcerative colitis and Crohn's disease. IL-12/23 medications like ustekinumab is available as well for UC and Crohn's disease, and then there's JAK inhibitors such as tofacitinib and upadacitinib for ulcerative colitis as well. So we'll go into a little bit more detail, but just to kind of give you an overview of what's available. So just in terms of mild to moderate ulcerative colitis, there was just a question in the chat, so let me just click on this for a second. Okay, sorry. So just in terms of 5-ASA medication, so as I had mentioned, you can use oral or rectal therapy. So if you have more distal disease, you can use suppositories, which target the last 15 centimeters. If the inflammation is a little bit higher to 20 to 30 centimeters, you can use enemas, so 5-ASA enemas. And if they have more extensive disease, so anything beyond the splenic flexure, those are the patients that you can use oral therapy. If topical and oral medications don't work, you can also use corticosteroid foams or enema as well to help get patients into remission. So about 70% of the time in patients with ulcerative colitis, you can get them into remission with 5-ASA medications. There are some side effects with 5-ASAs, the main ones being interstitial nephritis, which can happen very rarely. So usually we typically recommend doing a creatinine once a year and maybe a urinalysis. We used to use sulfasalazine in the past, but we don't typically use a lot of it now because we have much better access to the 5-ASA medications. And we know that the sulfasalazine medications or the sulfa medications have a lot more side effects associated with them. So we tend to stay away from sulfasalazine and don't use it as frequently. So in a patient that comes into the clinic with a flare of symptoms, as I mentioned before, we know that C. difficile is, there's a higher risk of having C. difficile. And so that's why routinely we always check for C. difficile in anyone that comes in with infectious symptoms. And also we do a stool culture and sensitivity. And then we also get our CRP, fecal calprotectin, to make sure there's objective evidence of active disease. And so in that patient with mild to moderate disease, for ulcerative colitis, again, like I said, if it's more left-sided disease, you can use topical treatment plus minus oral treatment. And if you do well on that, then you can maintain on 5-ASA medications. If you don't respond, then you can use steroids, either corticosteroids like prednisone, or if available, you can use budesonide MMX, which is sort of a therapy that kind of gets released a little bit more into the colon, things like Cortiment. And then if you have anything beyond the splenic flexure, then those are the patients who use both oral and rectal therapy plus minus steroids. And if you respond, then you maintain treatment. Whereas if you don't respond, those are the patients that need oral steroids. And if you don't respond to steroids, then those are the patients that end up needing biologic medications, usually infliximab, in patients with moderate to severe disease that isn't controlled with oral prednisone. In terms of mild Crohn's disease, so this becomes a little bit more difficult because the 5-ASAs don't work in Crohn's disease as much. There is some data that you can use sulfasalazine to induce someone into remission, but the data is not great and they're very old. And so you can consider using sulfasalazine to get patients into remission if they have colonic Crohn's disease. But the problem is that it's not really been shown to be effective for maintenance therapy. So sometimes it doesn't really work all that well. And in terms of if you have more TI disease or right colon disease, you can certainly use budesonide or Entocort, which is a steroid that's released in the small bowel and the right colon, and you can use that to induce patients into remission. But again, the same problem, it's not a great maintenance agent. So you kind of need to come up with a different therapy for maintenance, whether that's immunosuppressive medications or biologic medications for Crohn's disease. So the biggest difference between UC and Crohn's for mild to moderate patients is that 5-ASAs work really well for ulcerative colitis, but they don't work so great for Crohn's disease. So if you fail your 5-ASA and your Cortiment or your Entecort, these are the budesonide types of medications that have less side effects associated with them. You can certainly use prednisone at 40 to 60 milligrams a day. And that's been shown to be very effective in inducing patients into remission. Again, the problem is that oral prednisone is not effective for maintenance of remission. So you can't use it in a prolonged period of time. And so there is a thought that if you are going to use oral steroids, then those are the patients that you need to come up with a different plan or bridge to therapy. And usually that ends up being biologic therapy. So these are some of the side effects that you've seen with that you see with prednisone. So I won't go into all of them, but just to summarize, that there is a lot of issues with prednisone, long-term prednisone use, including osteopenia and osteoporosis, glaucoma, cataracts. There's high risks of infection and high risks of mortality with long-term prednisone use as well. So just in terms of corticosteroids, so if you started, they should start feeling better in the next 1 to 2 weeks. If the patient doesn't respond in the next 1 to 2 weeks, you need to consider alternative treatment. And then you taper slowly, and we usually taper about 5 milligrams per week if you're going to start something like prednisone. And again, just to highlight that if you are going to use steroids, you use it as a bridge to a different treatment, i.e. usually biologic medications. So in terms of biologic medications, I think I just wanted to show you this sort of diagram. So there's a lot of new biologic medications that are available, and they sort of interact in different parts of the inflammatory cascade. So JAK inhibitors sort of work on the JAK receptors and sort of prevent inflammation sort of higher up in the pathway. And then there's the cytokine targeting with IL-12/23 or the anti-TNFs that you're familiar with. And then there's lymphocyte trafficking blockade, and that's, you might be familiar with that with vedolizumab, which is the alpha-4 beta-7, or a newer medication called ozanimod, which is an S1P inhibitor, which blocks white blood cells from leaving the lymph node. So there's lots of different pathways that are available. And so in terms of patients that are failing the usual therapies with 5-ASAs for ulcerative colitis or steroids for Crohn's disease or are prednisone dependent or refractory, then those are the patients that you use biologic medications. And so you can certainly use anti-TNF monotherapy with or without thiopurine. You can use ustekinumab, which is the IL-12/23, vedolizumab. There's newer medications that have just been approved in the US and Canada. So there's risankizumab, which is approved for Crohn's disease, which is an IL-23 inhibitor, and ozanimod, which is that S1P inhibitor that stops white cells from leaving the lymph node. And then also the JAK inhibitors, which we're using mainly for second line right now. So those are medications like tofacitinib or upadacitinib for ulcerative colitis. And maybe afterwards we can have a discussion about what's actually available in Pakistan and what you use on a regular basis for your patients with IBD. So whatever you end up using, whether it's a biologic or combo therapy with a thiopurine, that's what usually you maintain them with. And the subset of patients that you induce them with steroids and are on immunomodulators, you can sort of continue the immunomodulator. I've been using a lot less immunomodulators over the last few years, just because we have easier access to biologic medications. There's biosimilar medications that have brought the price down as well. And so we're using a lot more biologic medications as opposed to thiopurine medications. And one of the reasons why we do that is because there have been a couple of studies that have shown that azathioprine early on in the treatment course doesn't seem to help very much in terms of preventing patients from having a flare. And these are two studies, the RAPID study and the Aztec study, which I guess now are 10 years old, but didn't really show a benefit over placebo in keeping patients in remission. So that's one of the reasons why you use a little bit less of azathioprine and thiopurine. And so the other reason that we're using less of them is because there's a lot of side effects associated with them, which you're probably familiar with, including the GI side effects like nausea and vomiting. There's hepatotoxicity, you can get pancreatitis, bone marrow suppression, and then there's also a risk of malignancy of lymphoma, particularly non-Hodgkin's lymphoma, which is a slightly higher increased with patients on immunosuppressive therapy. In terms of the biologics that are available and the safety issues with those medications, oral small molecules, you're probably familiar with the anti-TNF and the risk of infectious complications like latent tuberculosis. And this is one of the reasons why we check for TB before we start patients on an anti-TNF. You can sometimes get an autoimmune or lupus-like reactions, and it's contraindicated in patients with severe CHF and demyelinating disease. The newer biologic agents like vedolizumab, ustekinumab, and risankizumab, which is the IL-23, are generally safe with no increased risk of infection. So more and more, we're using these newer medications over anti-TNFs because they seem to be equally as effective in most cases, and they have a better safety profile. The oral JAK molecules, so tofacitinib or upadacitinib, are very effective in patients with ulcerative colitis, but there is some higher risks of herpes zoster, maybe a higher risk of DVTs and cardiovascular events, and it can alter your lipid profile as well. And ozanimod, as I mentioned, is a newer medication, that S1P inhibitor that works well and is relatively safe. You just have to do an EKG prior because sometimes it can cause bradycardia and it can cause macular edema as well. And so the recommendation is to do an eye exam in patients with diabetes. So how do we choose one biologic versus another? And so there's a variety of different factors that are that play a role. So there's drug factors. So if you have more fistulizing disease, you might use more of an anti-TNF medication, whereas if you have an older patient, you might use something that's a bit safer, like vedolizumab or ustekinumab. There's patient factors, so whether the patient's okay with a sub-Q dose or an IV dose, or requires oral dosing. Physician factors, so what your personal experience is with each of the drugs and what your how easy it is to get. And then there's drug factors that certain drugs work better with certain types of clinical patients, and immunogenicity is an issue as well. So we know that for patients that are on anti-TNF, there's a higher risk of developing antibodies, and so those patients sometimes need combo therapy with an immunosuppressive or thiopurine agent, and so that plays a role in terms of which medication you would use in what circumstance. So there's no real good studies to say that one biologic is much better than a second biologic. And so in terms of head-to-head studies, there's only been 2 head-to-head studies that are available in patients with IBD. This is the VARSITY study comparing vedolizumab and adalimumab. And what they found was that vedolizumab was more effective in getting patients into remission compared to adalimumab. So for ulcerative colitis patients, if we're deciding between the two, we would usually pick vedolizumab over adalimumab for ulcerative colitis. There was a head-to-head study in Crohn's disease as well, comparing ustekinumab and adalimumab, and what they found is that they were both equally effective in getting patients into remission. So there wasn't really a benefit of one versus the other. So in clinical practice, you could consider using either of these agents. There's a few more head-to-head studies that are coming out. There's one that's actually coming out very quickly that will be presented in October, which compares an IL-12/23 Stelara versus an IL-23, which is risankizumab, and that's in Crohn's disease patients. So we'll have a bit more information about which drug we think is the best drug to use with all of these different biologic options that are available. So just to sort of finish off, and then we can sort of have some questions, just in terms of chronic disease co-management. So, obviously we follow these patients with family physicians and other physicians in the treating team. And so just to get an idea of what we would usually do in patients that are on these different medications. So, the mesalamines, as I mentioned, you do renal functioning. So you measure a creatinine once a year. Corticosteroids, you're considered doing an ophthalmology exam because of the risk of macular edema. And obviously come up with a plan to avoid long-term steroid use. Thiopurines, regular CBC and liver enzymes every 3 to 4 months, and the same thing with methotrexate. Anti-TNF and ustekinumab, do the TB skin testing, and then regular labs every 4 months or so. Vedolizumab, just routine testing every 4 to 6 months. and tofacitinib and upadacitinib, the JAK inhibitors, routine labs. The Shingrix vaccine, which is sort of the non-live variant of the herpes zoster vaccine, is something that's recommended for patients starting on JAK inhibitors because of the high risk of reactivation associated with JAK inhibitors. Just a quick word about pregnancy. We always like to avoid antibiotics and steroids in the first trimester because of risk to the baby. All the biologics and thiopurines and 5-ASAs are safe in pregnancy and breastfeeding. The only medications that aren't safe are methotrexate, the JAK inhibitors, that's tofacitinib and upadacitinib, and the new S1P modulators, ozanimod, just because we don't have enough data with them. And in general, any patient on a biologic agent, we recommend that they don't have any live vaccines for 12 months. And so that usually in Canada, that means there's no rotavirus vaccine. That might be different in different jurisdictions. Vaccines are recommended for all of our patients with inflammatory bowel disease, and it's the usual vaccines that we would give any other patient. Live vaccine should be avoided in patients that are on biologic medication because there might be a risk of reactivation. And then just to finish off, in any patient that has a disease flare, so patients that's doing well and saw the gastroenterologist, but now is following up with their family doctor and has a flare, while you're waiting for the GI follow-up, you can certainly do some testing to make sure there's no infection. So rule out C. diff or any bacterial infections, and just complete routine labs, a CRP and fecal calprotectin, so you have an idea of what the degree of inflammation is. Sometimes the issue could just be compliance, that they're not taking their medications on a regular basis. So that's very important. And if they're already on a 5-ASA, you can also consider increasing the dosing or adding enema. Same thing with Crohn's disease, rule out infection, routine labs, CRP, fecal calprotectin. And if the symptoms are worsening, you could consider using steroids. If you're not a gastroenterologist and you're following the patient as a family physician, then obviously speak to the GI with regards to any issues. The one thing that can sometimes happen is because patients are on steroids or immunomodulators, anti-TNF, they have a high risk of infection. So there should be a high index of suspicion if there's fever or infectious symptoms. So I'll just summarize here with this slide. So in patients that come in with GI symptoms, using that red flag questionnaire is quite important and kind of helps differentiate the IBS patient or patients that are having IBS symptoms versus patients that have active disease. And you can use CRP and fecal calprotectin as adjunct testing. And if you have an elevated fecal calprotectin, that usually buys them an earlier visit to the gastroenterologist. Mucosal healing is the target, and for our treatments, and we sort of optimize or change therapy to try to get there. And we can use fecal calprotectin to help guide treatment. There's increasing use of biologics and oral small molecules, especially with the biosimilars that are available in generic molecules. So cost is becoming less of an issue, and so we'll have better access to these medications across multiple jurisdictions. And then finally, these patients are more complex patients, and so there's a lot of communication that has to happen between the primary care physician and the gastroenterologist as well. So I'll stop there. Here's my email address if you have any questions, or you can also follow me on Twitter. And maybe I'll stop there and I'll stop my sharing. And if there's anyone that has any questions or comments, I'm curious if there is any gastroenterologist or someone that deals with IBD, is there free access to the biologic medications, or is it very hard to get?
Thank you, Waqqas. Excellent talk. Can you hear me?
Yes, I can hear you.
Right. I'm Professor Altaf Alam. I'm a retired professor of gastroenterology and hepatology from Sheikh Zayed Hospital, and now doing office practice in a private hospital. I'm here because I'm the course director for PARSA ECHO, and for IBD ECHO, I'm also the course director. So, that is my another role. Excellent talk. I must thank you for your time and summarizing so beautifully in 25 minutes the whole difficult topic of treatment of IBD. So thank you very much. in terms of availability of the drugs that we use, 5-ASAs, azathioprine, of course, prednisolone is available. Budesonide is available with a bit of difficulty, but it is smuggled into this country, so we can still get it for select group of patients who can afford it because it's very expensive. In terms of biologicals, anti-TNF, particularly infliximab, is freely available. Adalimumab is not that freely available, but we can get it with contacts from the pharmacists or the parent company. Tofacitinib has recently become available and is being used in patients with IBD. So in terms of biologicals, we have anti-TNF and tofacitinib. The rest are not, available so far in this country. So we are a little bit limited, but somehow, particularly in ulcerative colitis, we are able to manage with 5-ASA, azathioprine, and intermittent steroids treatment. So this is just a background of what we have in our armamentarium for IBD in this country. Of course, we are limited, but not to that extent, and we can improvise and treat most of the patients fairly effective. So over to you, Waqqas.
That's great. I mean, I think, with infliximab and tofacitinib being available, you'll be able to sort of capture those more severe patients as well. So you have a couple of options for those patients that aren't doing well on 5-ASA medications. So that's good to hear. There was a question about allopurinol and heterozygous TPMT deficient patients. So I've used that a little bit in the past. And so, as you mentioned, if you're going to use allopurinol in someone that has a low TPMT, then that's one option. So if you have a very low TPMT, or if you do your 6TG and 6-MMP levels, and you see a large ratio of greater than 30 between the 6-MMP and the 6TG, those are the patients that do best with allopurinol. And so if you start allopurinol, usually 100 milligrams, you start a very low dose of azathioprine, about 50 milligrams, and then you can monitor them and also check their 6TG level. So I've done that a few times in patients that have sort of an altered metabolism, in terms of, so if you have an altered metabolism, so you have a higher 6-MMP to 6TG ratio, then the allopurinol is helpful. I'm just going to correct myself. So in the low TPMT, we don't typically use allopurinol. It was just what we usually do is just give a low dose of azathioprine. It's really the patients that have that high ratio between a 6-MMP and a 6TG, so more than a 30-to-1 ratio between 6-MMP and 6TG. Those are the patients that do well on allopurinol, and those are the patients that we would use 100 milligrams of allopurinol and 50 milligrams of azathioprine to follow them. And typically, those patients end up doing quite well with that recipe. But again, just to clarify, if you have a very low TPMT, if it's like below 30 or you're heterozygous, then you just use sort of a dose reduction. In those patients at low TPMT, probably considering allopurinol, probably a very low dose of azathioprine with those patients. I hope that makes sense.
Right. Do you routinely recommend, or in practice, check TPMT before prescribing azathioprine, or you just start slowly and build up the dose?
Yeah, so it depends on accessibility. So in my jurisdiction, it's freely available. So we do check TPMT for all of our patients, but in some jurisdictions it's not available, and so then those are the patients. So you start lower doses and gradually increase. But the benefit is if you have a normal TPMT, you can start full dose azathioprine at the same time.
It is TPMT levels is done in Pakistan, but it's an expensive test here, so it's a luxury. It's not a routine practice for us.
Yeah.
But if the patient is paying out of pocket and they can afford it and they are aware of all these problems, it is better to check it. because otherwise, all these legal issues that arise if you don't check it. And the patient is aware of it and can afford it. So these are some of the reasons where I check TPMT. Otherwise, I just start slowly and get on with it.
Yeah. I think either would. Sorry, go ahead.
Yeah, please go ahead, please.
No, if there's any other questions, I can certainly answer them, but
any questions, please? You can just unmute yourself, introduce yourself, and ask the question, please. Any question, any comment, maybe from any of the attendees? It seems you have given a very good talk, and it's, they have understood each and every aspect. So well done. All I can say, I hope some questions do arise in due course.
I mean, if you have any questions and you're shy, you can always email me and I'll be happy to answer them. And, inshallah, hopefully I'll make a trip to Pakistan at one point, back to Pakistan. It's been a while since I've been there. So I would like to make a trip, and hopefully we'll get a chance to see each other then as well.
Thank you very much. It would be a pleasure having you here. Right. Anyone, any comment or any question?
Assalamu alaikum, sir. Can you hear me, please?
Yes.
Yes. I'm Dr. Abdul Qudus, working as Associate Professor Gastroenterology. This was an excellent presentation. I just want to ask regarding when we stop the medication in the patient who are in the remission, is there any endpoints for treatment for these patients? Because most of the patients are concerned that this it's become difficult to take the medication throughout their life. I just want to ask regarding the stoppage of medication if the patient is in remission and we have achieved the mucosal healing and the say call protecting level become negative, and biopsies also doesn't show the evidence of active disease. Please give any comment.
It's a good question. I mean, I think in general, IBD is a chronic disease that you're stuck with for your whole life. So if you need treatment, then most of the time you're going to continue needing treatment, and there's always the chance of having a flare if you stop treatment. I think in patients that are on 5-ASA medications, I think we should encourage them to continue because it's a relatively safe treatment and not as costly. And it does, if you're adherent to it, it does prevent flares. So I think for the most part, if you have more moderate disease or extensive disease, those are the patients that you would probably want to continue treatment. If you have very distal disease like UC proctitis or left-sided disease, then some patients use a suppository and enema as needed, 1 week out of the month or every second or third day to kind of keep themselves in remission to sort of lower the frequency of dosing. That's for the 5-ASA medications. In terms of patients that are on thiopurines or biologic medications, for the most part, we sort of suggest to continue medications and not stop them because we know the risk of relapse is pretty high. So we know that, if you stop someone on a biologic medication, even if they're still taking the thiopurine, the risk is about 50% over the course of the next 2 years or so. So there's a pretty high chance of relapse. And one of the issues with infliximab is that if you stop it and try to restart again, you can also develop antibodies as well. And it might not work as effectively. So generally, when patients ask me to stop, I kind of tell them that it's a chronic disease. You can try stopping it. So in patients that have, as you mentioned, endoscopic, biochemical, and histologic remission, those patients end up doing a little bit better when you stop, and maybe can last a little bit longer before they need retreatment. And most of the time, you can recapture those patients with the reintroduction of the biologic medication. So if a patient really, really wants to stop, or has a specific reason for stopping, then in those patients that are in complete remission, endoscopic and histologic, you can consider stopping the medication, but the patient should be aware that there's a very high risk of relapse and that you'll be able to recapture maybe about 80% of patients, but not 100%. So there's about a 20% loss of capture rate. So if you only have infliximab available in your jurisdiction, that might be an issue if you sort of lose response to it or develop antibodies. But I guess at this point you have tofacitinib as well as another option. So it's all things that you need to have a discussion with the patient. So in general, we counsel patients to kind of continue their medications, but in special circumstances where patients really want to stop, then it's more of a risk-benefit, conversation that you have with the patient.
Thank you. Waqqas, another peculiar thing in Southeast Asia, in particular in Pakistan, is that our patients don't like enemas or suppositories. The reason being that, not everyone has their own bedroom and bathroom facilities in their house. A lot of people living, sharing the same bedroom, same washroom. So, it's not a very convenient thing in our setup. So, moreover, these are not available here. So if we want to give somebody an enema, we have to ask the pharmacy to make it for us. So we give them, say, hydrocortisone 100 milligram enemas each night, and they will make it for us, and they put it in a enema bottle and use it that way. So it's not a very commonly used armamentarium in our country, enema form. Moreover, all the steroid foams, enemas, and suppositories, and even 5-ASA enemas are not available. So we have to ask the pharmacy to make it for us, for our patients if needed. So that is another issue.
Yeah, I mean, I think not a lot of patients like using suppositories and enemas, and so even if you have, in my patients that have left-sided disease, I usually give them oral therapy at the same time. And so I usually tell them, if you can do it for a good 6 to 8 weeks just to get you into remission, because we know that the combination of oral and rectal 5-ASA is better than either one alone. And so if you can do both for a good 6 to 8 weeks, then you can maintain the patient just on oral therapy. So there's obviously some patients that will only respond to, suppository, but most of the time you're able to, start the oral therapy and have them sort of maintain their remission on oral therapy. Just the induction period sometimes is a bit more helpful to have both if it's possible.
Any other question, please, or comment from the audience? If you don't want to ask personally, you can put it in the chat box. We'll look at it and answer your question. Okay, so it seems that we are all very clear about the subject of drug treatment in IBD. So it remains for me to thank Dr. Waqqas Afif is, for taking out time from your busy schedule and talking to us. And as mentioned, we would love to see you physically in person. So wait for our invitation to attend one of our annual meetings, and certainly we would love to see you.
Yeah, that would be amazing. Thank you.
Just one question has appeared in the chat box. It is the biologics price in Pakistan. Well, I'm sure Waqqas cannot answer this question, so I'll chip in. Remicade or infliximab is available for in a normal size adult for about 100,000 per shot. So you need to make sure that your patient can afford it. So rupees 100,000 for one shot. So you start on day 1, 2 weeks, 6 weeks, and then every 6 weeks or so, then you have to continue and you have to be aware of the price of this agent. A biosimilar made in India is also available, which is cheaper, but not to that extent. It is available for a cost of something like 40 to 60,000, depending on your source, for one shot. Tofacitinib is available at the cost of around 30 to 40,000 rupees per month, depending on what dose you are using. 5 milligram twice daily is what we usually start with, and it costs around 30,000 rupees per month. So, you know, it comes with a price tag, and you have to be aware of that. So it's not cheap, in short. Thank you. So we were in the process of thanking you for taking time out, and all the participants for joining us. It was a good attendance today. So thank you very much, everyone, and particularly Dr. Waqqas for taking time out of his busy schedule and enlightening us on this important topic of drug treatment in IBD. So over to Uzair to call off this session. Thank you very much once again, Waqqas.
Sure,
Thank you very much.
Thank you very much to all of you from our end as well. And special thanks to Janex Pharma for providing us unrestricted educational grant. Thank you, sir. I am going to call off this meeting.